All right, let's talk about one of the most crucial skills you're going to master in your intrapartum rotation, managing pain during childbirth. And look, this isn't just about meds. We're talking about hands-on skills, being incredibly observant, and knowing exactly when and how to intervene.
So let's get right into it. The pain of childbirth is, well, it's different, right? It's a signal. It's productive pain, telling us that things are moving along. But here's the thing. To your patient, pain is pain. So the real question for you as the nurse is, how do you walk that line? How do you manage it safely and effectively for both mom and baby? This is where your skill really shines.
So here's our game plan. We're going to start with what labor pain actually is. Then we'll get into your hands-on interventions. We'll clear up the whole analgesia versus anesthesia thing, dive into nerve blocks, and wrap up with how to handle those critical side effects. Let's jump in.
Okay, section 1. Look, before you can do anything, you have to understand what you're up against. Labor pain is so much more than just the contractions themselves.
You know that 1 to 10 pain scale? Well, in labor, you kind of have to throw that idea out the window. Pain is so subjective. Think about it. Physically, the intensity of labor, the baby's position, that all matters. But then you've got this whole other layer, her culture, her anxiety level, whether this is her first baby, who's in the room with her. It's a whole puzzle, and you're the one putting the pieces together. And this right here, this is the big bad guy you're fighting before you even think about medication. The fear, tension, pain cycle. It's a vicious loop, right? The patient gets scared, her body tenses up, and that tension makes the pain 100 times worse, which, of course, makes her more scared. Your number one job, before anything else, is to be the cycle breaker. You do that with your words, your presence, and your hands. Which brings us to your secret weapons. Seriously, these are your first and most powerful tools. And please, don't ever call them just comfort measures. These are legit, evidence-based nursing interventions that can completely change the game for your patient. Okay, first up, effleurage. This looks simple, but it is pure magic. You're using just your fingertips, making these light circular motions on the abdomen. The key is to sync it up with her breathing during a contraction. What you're doing is sending a different signal to the brain. It's like you're creating gentle, pleasant noise that makes it harder for the pain signals to get through. It's a fantastic way to help her relax and feel more in control. And then there's this hero move, sacral counterpressure. If your patient is complaining of terrible back labor, you know that intense pressure in her lower back, which often means the baby is sunny side up, this is your go-to. You find that spot on her sacrum and just apply firm, steady pressure with the heel of your hand or your fist. You're literally pushing back against the pressure of the baby's head. The relief can be immediate and profound. Trust me, this one is a total game changer. Okay, so we've covered your hands-on tools. Now let's switch gears to medications. And listen up, because this next part is one of those things you absolutely have to nail down. The difference between analgesia and anesthesia. They are not the same thing. Think of it like this. Analgesia is like a volume knob for pain. We're turning it down. The patient still feels pressure, she knows the contraction is happening, but the sharp edge is gone. Opioids are a great example. Anesthesia, on the other hand, is like a mute button. We're aiming to completely block the pain signals from ever reaching the brain. That's your epidural. So are we turning it down or are we turning it off? That's the core difference. So when we're talking about those opioid analgesics like fentanyl, you have to be on high alert. We give it IV because it works fast, which is great, but it can make mom drowsy and nauseous, and you might see the baby's heart rate variability dip on the monitor. And the absolute biggest risk, the one you always have to be thinking about, is neonatal respiratory depression. If you give it too close to delivery, that baby can be born not wanting to breathe. And that brings us to your nursing actions. This is your safety checklist. First, make sure she's really in active labor. Don't give it too early. Then, you're glued to those maternal vitals and the fetal heart rate strip. Have some anti-nausea meds handy. But the single most important thing on this list? Have Narcan ready. Naloxone. It's the reversal agent for opioids. You have to be prepared to give it to the baby if needed. This is not optional, it is a critical safety measure.
All right, let's move on to the big guns of pain management, nerve blocks. We're going to break down the two main types you'll see all the time, the epidural and the spinal.
This chart breaks it down perfectly. The big difference is where the medication goes. An epidural is injected into the space around the spinal cord. A spinal goes directly into the spinal fluid. Because of that, the effects are different. An epidural numbs you from about your belly button down to your thighs, ideal for labor. A spinal block is much more intense, numbing from the nipples all the way down to the feet. That's why it's the go-to for C-sections. All sensation is gone.
Now, once the anesthesiologist places that block, your job doesn't end. In fact, it's just getting started. Your role now becomes being the vigilant nurse, watching for and managing the side effects.
And here it is, the #1 side effect you need to be ready for. The most common complication of a nerve block is maternal hypotension, a sudden, sharp drop in mom's blood pressure. Why does this happen? Well, the anesthesia causes all her blood vessels to relax and open up, vasodilation, and her pressure can just tank. When that blood pressure drops, you have to move fast. This isn't a wait-and-see situation. This is your 4-step rapid response. First, turn her onto her left side. This gets the weight of the uterus off the major blood vessels and helps perfusion to the baby. Second, open up that IV fluid and give her a bolus. Third, put oxygen on her. And fourth, let the provider know you might need ephedrine to raise her blood pressure pharmacologically. These 4 steps need to become muscle memory. Okay, there's another potential problem we need to talk about. Sometimes, during the epidural placement, the dura, the tough membrane around the spinal cord, can get accidentally nicked. When that happens, spinal fluid can leak out, causing what's called a post-dural puncture headache. And these aren't just any headaches. They can be absolutely brutal. So what do?
First, we try the simple stuff. You're going to have your patient lie completely flat. This helps reduce the pressure and minimize the leak. We'll keep the room dark and quiet, give them pain meds, and push fluids and caffeine. Caffeine helps constrict the blood vessels in the brain, which can provide some relief. But what if that doesn't cut it? For a really bad, persistent headache, there's a more definitive treatment called an epidural blood patch. Anesthesiology will draw about 20 milliliters of the patient's own blood and inject it right back into the epidural space. The blood then clots and forms a patch over that tiny hole in the dura, stopping the leak. The relief can be almost instant. It's a really cool and important procedure to be aware of.
So, let's wrap it all up with this thought. The goal isn't always to have a totally painless birth. I mean, sometimes that's possible. But the real goal is for your patient to walk away from that experience feeling safe, feeling heard, and feeling empowered. You have this incredible toolkit: your hands, your knowledge, your voice. So the question to leave you with is this: how are you going to use all of it to strike that perfect balance for your patient?